Today's topic is about abdominal imaging, that is, the imaging that we use to visualize the human abdomen. So, let's get on with it. The human abdomen is a complex space. It houses all the viscera. It has the anterior abdominal wall, the lateral abdominal walls. Posteriorly, it houses the vertebral column along with the spinal cord, and there's a variety of viscera inside it, from liver to spleen to pancreas to the small bowel to the large bowel, and then there is the rectum. So, and all of it is bound by fascia. So all of it makes up a complex presentation. So a good doctor must be able to discern the abdominal X-ray. So which modality should we use in which case? Here an example. So first of all, we have the normal radiography, the normal X-rays that we use. Now this, if we use on the abdomen and we have the clinical data that there is some kind of abdominal pain, there is some distension, and bowel sounds are either active or absent, we perform this modality in order to rule out any obstruction. Now obstruction can be due to impacted stools, or it can be due to some carcinoma or polyps. Next modality that we use is CT scan with or without the contrast enhancement, but our focus remains on the pancreas. Now if we have the history with weight loss, there's a vague pain, jaundice, and dilated common bile duct, we do this modality in order to rule out if there is any acute or chronic pancreatitis, or if there is any pancreatic mass. Next modality, again CT scan with or without contrast, but this time whole of the abdomen along with the pelvis. Now if we have the history of having liver enzymes elevated, there's some history of a later stage carcinoma, especially if it's a lung carcinoma, we do this in order to rule out any metastatic disease. Next modality that we use is ultrasound. And along with the normal X-rays, it is the most commonly used modality of the abdomen. Now, it is usually limited to the right upper quadrant of the abdomen. Now, if we divide the abdomen into four corners, there would be the right upper, the left upper quadrant, the right lower quadrant, and the left lower quadrant. Ultrasound is usually reserved for the right upper quadrant in order to visualize the gallbladder and the liver. Now if we have the history of acute pain from the right upper quadrant, and there is some chance there's some history of fever or increased white cell count, that is leukocytosis, then we do this in order to rule out any acute or chronic cholecystitis or cholelithiasis or cholelithiasis, that is the gallstones in the common bile duct. The next modality that we might use is the MRI with contrast. Now this is used again in the whole abdomen and pelvis along with the perineum. Now if we have a history that gives us mixed symptomology and the signs and symptoms are not certain, MRI is performed along with CT scan or any other modality in order to create a more accurate differential diagnosis or to confirm an already suspicion. Now, at this point, I must also indicate that we also perform PET scan, that the positron emission tomography, in order to stage any cancer in the abdomen and to evaluate the treatment for that said cancer. How that treatment is progressing, is it reducing the mass of the cancer, or is it not? Do we need to change it? PET scan is usually reserved for oncological purposes. Next, we have the abdominal trauma. Now, in the emergency department, one of the most common complaints after fracture is abdominal trauma. Now, abdominal trauma can both be blunt, that the injury and the damage is to the anterior or lateral walls, or it could be penetrating, that it has actually invaded inside the walls of the abdomen and may have even punctured some viscera or blood vessels. Now, if we have an history of abdominal trauma, it is always treated as an emergency. For this purpose, the imaging that we usually use is of chest X-ray. Now, why do we use chest X-ray in an abdominal trauma? I'll discuss this later. And we also use CT scan. Now, this CT scan can be enhanced or it can be unenhanced, but we usually perform CT scan in phases. Usually we perform an arterial phase and then we perform a delayed phase. Now, what is a phase of a CT scan or a window? This is all discussed in my lecture of Introduction to Radiology. Now, in abdominal trauma, the modalities that are used are ultrasound, that we use ultrasonography, then we use CT scan, and that CT scan is usually contrast enhanced. And then we used a very specific modality, which is called the FAST examination. Now, FAST here stands for Focused Assessment of Sonography in Trauma. Now, ultrasound is a very quick and very easy to do modality. It can be done in an emergency department. It does not require very high level equipment, but it usually has a probe and some kind of processor and a monitor with a display. For fast examination, we have an handheld device which gives us immediate and quick responses and images, and this can be done while the patient who has suffered trauma, either blunt or penetrating, while that patient is being resuscitated, is being stabilized, and is being treated on. So fast examination, being handheld and is of ultrasound origin, can be performed in the emergency department. CT scans, chest X-rays, MRIs cannot be performed in the emergency department because they require heavy equipment, and for those to succeed, we need to stop the treatment of the patient. But for the ultrasound, and especially for the fast examination, we do not require that. Both the treatment of the patient, the stabilization, and the fast examination can happen concurrently. And that is the reason the fast examination is standard in ATLS. Now, ATLS stands for Advanced Trauma and Life Support. Now, this is a course which all doctors must go through. It tells us how to deal with anyone who has suffered for trauma in any site, and how to perform life support on that patient, how to keep him stabilized, and how to perform which treatment, and how to prolong his life, either in the emergency department or at the site of the trauma. Next, for the abdominal trauma, all of these modalities give us certain interpretations. Now, if we have fast examination, it will, if there's trauma, it will give us an image of intraperitoneal fluid. Now, after a trauma, blunt or penetrating, if there is evidence of intraperitoneal fluid, it is usually blood. So there is some hemorrhage, some bleeding that is going on inside the patient. If the trauma is blunt, not penetrating, and the hemorrhage is happening inside the patient, that requires immediate surgery, and that also requires immediate stoppage of the blood of that patient. So embolization of that artery must, or vein must be performed, and that bleeding must be stopped in order to make the patient hemodynamically stable. Another thing is that we perform contrast enhanced CT. If our patient is not hemorrhaging, he or her is hemodynamically stable, so we perform a contrast enhanced CT. And in that contrast enhanced CT, we usually perform first an arterial phase in order to find out the location of the bleed. Now, fast examination can tell us that there is hemorrhage inside the abdomen, but it cannot tell us the actual site of hemorrhage, the actual site of the bleeder from which the hemorrhage is happening. Now, for that to know, we need to perform contrast enhanced CT scan, but in arterial phase. And in arterial phase, it will tell us where that bleeder is. And following that, we perform a delayed phase, which takes about a minute or two, in order to find out if there are any other damage or laceration that the patient might have suffered. In this example, the patient has suffered lacerations and injury to his liver, which can be seen here. The hepatic laceration. Next, we have the abdominal pain. Now, as I stated earlier, abdominal pain is usually diffuse and it's not specific. Why? Because the nerve distribution, the neurological distribution in abdomen is not that extensive, and usually the pain that we feel are either of diffuse quality, are usually referred, that they are not actually at the site of the problem, they migrate, and they even have different intermittent quality to them. So an abdominal pain is diffuse and usually not that accurate, but still, if the patient complains of the pain, we have to perform the examination. We have to perform the radiological examination or the abdominal x-ray along with the chest x-ray. Now, one of the most common example or causes of abdominal pain is the bowel obstruction. Either the small intestine or the large intestine is blocked. Now, that blockage can be due to a stenosis, can be due to some kind of polyp or carcinoma, tumor, or it can be even due to impacted stools. Now, here is an example of bowel obstruction. This is the air inside the large intestine that is blocked, and the air is trapped inside the bowel. And this is the X-ray. This is the CT scan, an axial one, and here, which is in the supine position, and this black area, the hyper enhancement, shows us that air is present inside the bowel and it is trapped and it is not moving forward due to some kind of an obstruction. Another cause of pain is pneumonia. Now, pneumonia is a disease of lung where consolidation occurs in either the right or the left or both lungs. Now, why do we perform chest x-ray in abdominal pain? Now, there are usually three reasons. The first reason is the pneumonia, because sometimes the pain of pneumonia is not referred to the chest, to the anterior thoracic wall, but it is actually referred to the anterior or the epigastric area, anterior abdominal wall or the epigastric area. So we have to perform the chest x-ray because if the patient is suffering from pneumonia. Now that pneumonia can both be an obstructive pneumonia, such as in this case where the whole bronchus is obstructive and the upper area of the lung is consolidated, or it could be an lobar pneumonia where a lobe of the lung is obstructive. In either case, the pain is referred to the abdominal wall instead of the thoracic wall, and the usual site is the epigastric site. Now, apart from pneumonia, another reason that we perform chest x-ray in an abdominal pain is because of free abdominal air. Now, one of the example would be here. Now, this chest x-ray here has air under the diaphragm, but on the right side. The normal air under the diaphragm is usually on the left side, but if it's on the right side, that indicates that some free air is present inside the abdomen. Now, if we perform the CT scan of the same patient, we will see that air is actually present both superiorly to the liver and anteriorly to the liver, and the source of this air could be a perforated bowel. It can be small intestine, it can be large intestine. Whatever the cause is, presence of air inside the abdomen, which is usually seen on the chest x-ray on the right upper quadrant, is abnormal and must be investigated further. Another reason to perform chest x-ray for a patient in abdominal pain is to get GA fitness, that is the general anesthesia. Whenever a patient with trauma undergoes surgery, GA fitness must be performed. So in order to see that if that patient has any thoracic problem, chest x-ray is performed to measure the chest, the GA fitness of the patient, if the patient is fit to have general anesthesia and if the surgery can be performed on the patient. Now, one of the most common site and disease and condition that causes abdominal pain is acute appendicitis. Now, acute appendicitis is actually inflammation of the appendix. Appendix is a small appendage on the right lower quadrant of the abdomen, which is a vestigial organ, that it serves no real purpose. But during normal peristaltic movement of the intestine, sometimes fecal matter gets trapped inside the appendix, and because of that entrapment, appendix might inflame, and because of that inflammation it might get infected, and because of that infection a patient with fever and high white cell count along with right lower quadrant pain is usually a sign of appendicitis. Now here is the patient. This coronal CT shows us that patient has inflamed appendix, and this axial CT scan tells us that this is the appendix of the patient. Now this should have small lumen and there should be no thickening of the lumen, but this shows that there is thickening of the lumen has dilated, and there might even be edema, periedemal, outside the appendix. All of these points show us that patient is suffering from acute appendicitis, and usually appendectomy is performed. That appendix is simply cut out and removed from the patient. Another cause of abdominal pain is usually an abdominal aneurysm or an abdominal mass. Now, abdominal aneurysm can be visualized on an axial CT scan. Now, here in this CT scan, this is the aneurysm which has ballooned out and there is blood inside of it. Now, this aneurysm might get ruptured and patient might become hemodynamically unstable, or it might not get ruptured. In either case, this must be dealt with. Sometimes what happens that during the physical examination we find a mass in the abdomen which is pulsatile. A pulsatile mass is usually indicative of an abdominal aneurysm. So this CT scan, the patient of this CT scan will have a pulsatile mass on examination. But not all masses are pulsatile. Some masses are solid, some are mobile, and some are even tender and painful. Now this again is an example of a pulsatile mass, because its pulsatile is continuously moves, and because of this movement we have this hazy movement of the mass. This hazy movement of the mass tells us that the mass is pulsatile, that it is throbbing with the heart. So it might be an aneurysm, it might be an aortic dissection, it can be anything. So whatever the cause is, a pulsatile mass must always be dealt with, must also be surged upon, because it can lead to rupture and hemorrhage. Now, abdominal pain, again, like I said, one of the major causes of abdominal pain is bowel obstruction. And usually bowel obstruction leads to accumulation of air inside the intestine, and that intestine might get perforated, and that perforation causes air to escape inside the abdominal cavity. And this air is usually represented by the right upper quadrant air, like here. This is the diaphragm and this is the free air that is present. Now this is an upright radiograph. Because it is upright, all of the air has moved upward because of the gravity, because it is lighter. If it was a supine, all of the air would have moved anteriorly to the anterior thoracic valve. Now this is the intraperitoneal air, this is the liver, and here we have air inside the small intestine. Now, because of the small intestine has a lumen that is small, whenever air is entrapped inside it, it bulges out, balloons out, and sometimes gives an impression of mass on examination. But it is not a mass, it's a pseudo mass, you can say. And upon the relievement of the obstruction, the air escapes out, and that ballooning out and that appearance of the mass is relieved and it vanishes. So dilated small bowel loops can also give an impression of a mass. Now, in a supine position, air inside the small intestine can either inside the bowel can either be in the small intestine or inside the large intestine, that is the colon. Now, how we can differentiate between them is through the folds. Now, you can see that here the folds are small, they do not go all the way, and they are discontinuous. These folds are called haustral folds, and they are specific only to the colon, to the large intestine, because in the small intestine these folds run along the length of the lumen, as we witnessed in the previous radiogram. Now, whenever there is a small bowel obstruction, not only air is entrapped inside it, fluid is also trapped. Now, because fluid always finds its level, so an abdominal X-ray with large small bowel obstruction will give us multiple air fluid levels, like this level here, this level here, this level, and this level. This multiple air fluid level is what is called a step ladder sign, and this is indicative that there is obstruction and entrapment of the small intestine. Next, we have the paralytic ileus. Now, as I said, whenever there is fluid and air trapped inside the small intestine, it forms a step ladder sign that there are multiple air fluid level. But there is a certain condition called paralytic ileus. Now, in this condition, the small intestine loses its ability. It's a neurological disease where it loses its ability of peristalsis. So when there is no peristalsis, the small intestine bulges out, dilates, and forms huge loops and balloons. Now the important part is whenever there is paralytic ileus, the air fluid level is singular and large and huge. Now instead of multiple air fluid levels, there's only a single one. When there's only a single large air fluid level along with huge ballooning of the small intestine, it is usually indicative of paralytic ileus. When there are multiple levels, that means that only obstruction is happening. There is no paralysis of the peristaltic movement. Now, sometimes this can also happen in the large intestine. Now, the large intestine is composed usually made of the colon, the sigmoid colon, the rectum, and then the anus. Now, if there is some kind of rectal mass or a rectal polyp or even compacted stool inside the rectum, this will cause for the large intestine to balloon out, to have air trapped inside it, and this will result in a picture much like this one, where we have these are the haustral folds, these are the ballooning outs, this is the pelvis, and these are the haustral folds of the colon. So both we have discussed the paralytic ileus and the dilated large bowel. Now there is one very specific disease of small intestine where air and fluid and stool get trapped inside the bowel in the lumen because there is some kind of twist. Now that twist, that volvulus, which is called, blocks the small intestine. Now it is because it is blocked because of the twisting of the small intestine, we get a picture much like this one. Now these are the dilated bowels of loops of the sigmoid colon, and this is the site of the twisting of the colon. Now, because the colon has twisted, it has blocked, air has entrapped. But if we remove this twisting, which can be easily done by passing a flatus tube through the rectal area into the sigmoid colon, we can relieve the patient of the volvulus. But sometimes it's not that easy and surgery is necessary. So obstruction cannot only happen because of stools or polyps or cancers or impaction or stenosis. Sometimes even its own twisting can block the intestine. Now, as I mentioned earlier, whenever intestine is perforated, air escapes out into the abdominal cavity. But sometimes this escape of air doesn't happen directly. Sometimes it escapes between the layer of the intestine instead of going inside the abdominal cavity. So whenever air escapes between the layers of the intestine, it gives us a very specific picture where multiple lines of air and mucosal folds are stacked upon each other. Now this is called pneumatosis, and it is very common in certain diseases where the erosion of the normal bowel lumen makes the escape of the air between the layers very easy. Now, like I said earlier, one of the major causes of abdominal pain, especially in the right upper quadrant, is the presence of gallstones or the acute cholecystitis. Now, in this abdominal X-ray, we can see that this is the right upper quadrant and we have a collection of stones. Now these stones are actually present inside the gallbladder, and gallbladder is the organ which stores the bile which is made by the liver. So when these stones move from the gallbladder into the common bile duct, it results into both the inflammation and infection of the gallbladder. It results into the dilation of the hepatic duct. It can even result into the dilation of the common bile duct if it's much down. So gallstones can result into an acute cholecystitis picture, into a cholelithiasis picture. So if gallstones are observed in your abdominal X-ray, further studies must be done and surgery must be performed to correct it. Now this is an ultrasound of the gallbladder. This is the gallbladder and this is the gallstone. And this is present at the junction of the common bile duct and the hepatic duct. Now this is not the common bile duct or the hepatic duct. This is actually acoustic shadowing because of this huge gallstone. Now another cause of presence of calcification or stone inside the abdomen is appendicolith. Appendicolith is a condition where there is stone formation inside the appendix. Now this is a very serious sign because it can lead to the inflammation of the appendix and then the infection and can result in acute appendicitis. Sometimes on abdominal X-ray, we also see some concretions and stones in the left upper quadrant near the epigastric area. These concretions are of the body of the pancreas, and if these are present, this is indicative of an acute or chronic pancreatitis. So any kind of calcification or presence of stones in the abdomen must not be taken lightly, because it is indicative of variety of diseases at variety of sites. Then we have another condition called the hiatus hernia. Now, what is hernia? Hernia is the movement of a viscera through an opening from which it is not supposed to go through. Now, there are usually two types of hernia seen in the abdomen. There's the hiatus hernia and there's the paraumbilical hernia. In the paraumbilical hernia, small bowels try to move into the umbilical opening. In the hiatal hernia, what happens is that stomach tries to move in the opening made by the diaphragm near the vertebral column, and this is called the hiatal hernia. It is a very serious condition and must be corrected immediately through surgery. Now, in this abdominal X-ray, which is actually a barium study. Now, if you recall from my lecture of Introduction to Radiology, barium study or barium meal is a fluoroscopic study where a fluoroscopic compound such as barium is given to the patient. Patient swallows it, and then that barium moves through the stomach, then the small intestine, then the large intestine, and then it is excreted out. Now, as it is moving through the intestine, through the gastrointestinal tract, a series of radiographs are taken. Now, if there is a problem in the small intestine, it can be recorded. If there is a problem in the esophagus, it can be recorded. If there is a problem in the stomach, it can be recorded. Now, this is the barium study of the hiatal hernia, where there are two portions of the stomach, because the stomach has moved into the thoracic cavity through this opening of the diaphragm near the vertebral column. Now, hiatal hernia can also be visualized on a chest X-ray, where it is found behind the shadow of the heart in the form of a circular entity. Now, this object, which is circular behind the heart, is actually indicative of hiatal hernia, that the stomach has moved from abdominal cavity into the thoracic cavity through the diaphragmatic opening. Now, small hiatal hernia are not visualized on the chest X-ray, but large ones can be visualized. Next, we have the duodenal ulcer. Now, like I said, that there is a set of study called Barium Study, through which we can visualize whole of the gastrointestinal tract. Now, whenever there is an ulcer, it results in the erosion of the mucosal membrane. It results in the discontinuation of the intima, and it can also result in the thickening of the mucosa around it. Now, because of the erosion of the intima and the discontinuation of the mucosal membrane, this little area is actually a duodenal ulcer, where the barium is moving through the duodenum. This little pouching of the barium is actually discontinuation of the intima and the mucosal membrane inside the duodenum. Next, we have the cholelithiasis. Now, cholelithiasis, as discussed earlier, means presence of gallstones inside the gallbladder, which houses the bile which is made by the liver. Now, diagnosis of cholelithiasis is done by ultrasound. Now, this is the gallbladder, this is the concretion, this is the acoustic shadowing, this is the parenchyma of the liver. Now, because of the cholelithiasis, it has progressed into acute cholecystitis, which has resulted into inflammation and thickened gallbladder walls, as you can see here. And this bright echogenic area is a gallstone. And this area is not either the common bile duct or the hepatic duct. It is the acoustic shadow of this large gallstone. Then we have liver with steatosis. It has a common name, fatty liver. Now, fatty liver is usually found in either obese patient or patients with dyslipidemia, and it is diagnosed with ultrasound, and it gives a very specific picture where the parenchyma of the liver is not penetrated enough by the sound waves generated by the probe of the ultrasound. As you can see here, this is the diaphragm, this is the parenchyma of the liver, this is the right kidney, but this area is not visualized properly because the fatty area here has blocked the entry of the sound waves generated by the probe. And this is a very typical picture of liver steatosis, or otherwise known as fatty liver. Next, we have hyperechoic masses. Now, sometimes on ultrasound, we find hyperechoic areas like this one here. Now, we can say that it is hyperechoic because this area is isoechoic. This is hypo because it is a vessel, the lumen of a vessel. But this little area is hyperechoic, and it must be investigated further. But usually these small limited hyperechoic area are hepatic hemangiomas, which is a benign condition, but further studies must be done. Now, sometimes in cholelithiasis, there is not just one stone. There might be multiple stones, or there might be multiple small gravel called concretions inside the gallbladder. Now, in this ultrasound, we can visualize the gallbladder. It has thickened walls, but all of these are small concretions. Now, instead of a large gallstones, we have small multiple concretions, also called gravel, present inside the gallstone, and all of these are producing an acoustic shadow. Now, with ultrasound, one can also image acute appendicitis, like here. If appendix has dilated more than 7 mm, it has edema surrounding it, and it has thickening of its wall, it is very much pathognomic of an acute appendicitis picture. In this ultrasound, we can see that lumen of the appendix has distended. There is edema present around it. This is the edema that is present, and its walls are thickened. So this is a distended appendix which can cause acute appendicitis. Now, this is an acute appendicitis along with two appendicolits, which are the concretions or calculi inside the appendix, We can see that it is inflamed, it has dilated, and it has resulted in acute appendicitis. You can see both the appendicolith, the fluid around it, and its dilation. Now this edema is of very particular type, that it is mesenteric edema. That edema is not only covering the lumen of the appendix, but it is also covering the mesentery, the fascia that binds all the bowels together. Now, one of the complications of acute appendicitis is, if not removed through surgery, is a periappendiceal abscess. Now, in this axial CT, we can see that appendix. Now, this is an appendicolith. This is the appendix, and not only it has thickened in its lumen, there is also presence of abscess around it. So it means, and appendicolith has moved, so it means that appendix has perforated, and because of the perforation and leakage of the purulent fluid, abscess formation has occurred. So this is one of the complications of acute appendicitis if not removed promptly. Next, we have the diverticulitis. Now, diverticulitis is the inflammation of the diverticula of the large intestine. Now, diverticula are small pouches which start to appear around the colon or the large intestine, and this usually happens with age. It is not a disease, it is just a normal physiology where small pouches start to appear around the large intestine, and these pouches are called the diverticula. Now, if these diverticula become inflamed and become infected, just like the appendix gets inflamed and infected, it can result in diverticulitis, and this results in the left lower quadrant pain. Now, always remember, the right lower quadrant pain is usually due to acute appendicitis along with fever and leukocytosis, and left lower quadrant pain along with fever and leukocytosis is due to diverticulitis. Here we have an axial CT where this is the large intestine and this is the diverticula, which has both inflamed and increased in size. This is the lumen of the large intestine and this is the diverticula, which has inflamed in size. Now, diverticulitis can also happen in the sigmoid colon. We have a picture here. This is the sigmoid colon and this is the sigmoid mesocolon. Now, sigmoid mesocolon is the middle portion of the sigmoid colon, and diverticulitis can not only happen because of the inflammation or infection, it can also happen due to ischemic changes in the mesentery, in the lumen, in the vessels which supply the mesocolon, and sigmoid colon is supplied by superior mesenteric artery. So if there is some problem with the superior mesenteric artery, it can happen into ischemic changes which then become diverticulitis in the sigmoid colon. Next, I have an angiogram of the superior mesenteric artery. Now, this is the aorta. This is the celiac artery, and this is the superior mesenteric artery. Now, because of the atherosclerotic plaque, stenosis has happened, the blood flow has reduced, and because of this reduced blood flow, ischemic changes in the sigmoid colon has resulted into diverticulitis, that is the inflammation of the diverticula, SMA, or the superior mesenteric artery. Now, next topic to consider is jaundice. Now, jaundice is both a sign and a symptom where the yellowness of the skin of the patient starts to happen. Now, it is different from pallor because pallor is the absence of the reddish color of the skin. Jaundice is the appearance of the yellowish orangish color discoloration of the skin. The more the jaundice, the more discoloration of the skin. And this discoloration actually happens due to accumulation of bile pigment called bilirubin. I have a picture of a patient with jaundice. Now, as you can see, whole of his skin has a very yellow orangish tinge. There's some reddish blushing here which you can use to compare the discoloration. And this discoloration, an increase in the bilirubin in the blood, is termed as jaundice. It is also called icterus. Now, what are its causes? It can be caused by cholelithiasis, which means that the common bile duct is blocked. So bile doesn't flow from the gallbladder into the duodenum. The emulsification of the fats doesn't happen, and bilirubin is not released into the intestines. As bilirubin is not released into the intestine through the bile, it starts to accumulate in the skin. Another cause is the malignant biliary tract obstruction. Now, not only can gallstones can obstruct the common bile duct, but malignant biliary tumors or polyps or masses can also obstruct the common bile duct. Now, when it's obstructed, bile doesn't flow, bilirubin is not excreted out, and jaundice starts to happen. Another cause are the ampullary tumors. Now, ampullary tumors are the tumor of the ampulla of the pancreas, because the ampulla of the pancreas lies near the area where the common bile duct and the pancreatic duct join together into the duodenum. So any problem, any mass in the ampulla of the pancreas will result into the blockage of the either the common bile duct, or may cause its stenosis, and this will again cause reduced bile flow. Another cause is a pancreatic tumor. If the pancreatic tumor of the body of the pancreas is large enough to obstruct either the common bile duct or the ampulla or the hepatic duct or the gallbladder as a whole, it may stop the flow or the formation of the bile, which will result in increased bilirubin in the blood, that will result in jaundice. So these are the most common causes of jaundice in a patient. Now, let's talk about common bile duct. Now, if common bile duct is dilated outside the liver, it is usually due to either a gallstone or an ampullary mass or stenosis or some kind of tumor. But if it's dilated inside the liver, it might be due to some hepatic tumor which can press on it and cause the reduced bile flow can cause the bile to either form less, or its outflow through the bile canaliculi is reduced inside the liver. So hepatic tumors can also result in reduced bile outflow. But here the common bile duct is actually dilated in the liver instead of outside the liver. This is the portal vein, and this is the common bile duct, which should have a small lumen, but here, because of the dilation, because of the pooling of the bile, because there's obstruction down further down the duct, it has dilated. Now, due to obstruction of the biliary tract, it can result into dilation, as we witnessed earlier. But that was on an ultrasound. On a CT scan, this can result in a picture much like this, because biliary dilation can happen both inside the liver and outside. Now, if the dilation is outside the liver, it is usually due to cholelithiasis, that is the gallstone, which have introduced into the common bile duct. But if the biliary dilation is inside the liver, it is usually due to the presence of certain tumors such as cholangiocarcinoma, or if it results in the dilation of the both right and left hepatic duct, it can be due to a tumor called clastic tumor. In this picture, you can see the axial CT scan shows us that there's biliary dilation inside the liver. Now, as I stated earlier, that biliary dilation inside the liver is usually due to presence of tumor. Now, these tumors can be primary, such as cholangiocarcinoma, or it can be metastatic. Now, this is a picture of a metastatic tumors inside the liver. Now, the primary tumor can be anywhere from the lungs to the uterus to the ovaries to the intestines, rectum, but it has metastasized, and these metastasis tumors are causing the bile duct, the biliary system inside the liver, to dilate, as you can see on this minimally intensive projection of the liver. Now, what is a minimally intensity projection? For this, you have to refer to my lecture of the introduction to radiology. Now, not only it can happen because of tumors inside the liver, it can also happen because of tumors inside the pancreas. And this second slide, which is an oblique reconstruction, shows very clearly that there is a dilated pancreatic duct due to a pancreatic mass. Now, because of this pancreatic mass, the pancreatic duct has not only dilated, but it also has become tortuous because of its pooling of its excretion. Now, another way we can visualize these biliary and pancreatic tumors is through an MRI. Now, as you might recall, one of the most important study to study the hepatobiliary system is an MRCP, or magnetic resonance cholangiopancreatogram. Now, this is an MRCP where both the gallbladder, the hepatic ducts, the right and the left, and the common bile duct is visualized. But this is the area where the obstruction has happened, and because of this obstruction, bile has pooled inside and is causing biliary dilation inside the liver and outside the liver. Now, our next topic is GI bleeding or gastrointestinal bleeding. Now, gastrointestinal bleeding can result in three pictures: either hematemesis or the blood in vomiting through the mouth, or it can result in melena, which is a brown discoloration of the stools due to the presence of coagulated blood, or it can result into hematochezia, which is the presence of fresh blood in the stools. Now, whatever the picture is, GI bleeding must always be investigated further. The usual causes of abdominal GI bleeding is esophageal varices, gastric ulcers, duodenal ulcers. All of these can cause hematemesis and can cause GI bleed. Now, this is a catheter and CT angiography of the superior mesenteric artery, and this shows the extravasation of that artery. Now, extravasation is the pooling of blood outside the artery, and this angiographic studies clearly shows us that this pooling of blood outside the artery has resulted in some GI bleed, because superior mesenteric artery is present in the abdomen, inside the abdominal cavity. Now, like I said, that GI bleed can happen anywhere, from esophagus to duodenum to the stomach to the whole of the intestine to the rectum, even the anus. So sometimes even the endoscopic surgeries or the ERCP, that is the endoscopic retrograde cholangiopancreatogram, or the MRCP or the magnetic resonance cholangiopancreatogram, if these studies do not find, which are all endoscopic studies, do not find the source of the bleed, we perform a very specific test which is called a radionuclide GI bleeding test. Now, in this test, what we do is that we label technetium 99 to the red blood cells and take series of PET scan CT images. Now, these series of images, as seen here, show us where the pooling of blood is happening, because where there is bleeding, hemorrhage, red bloods will start to accumulate, and because those red blood cells are labeled with technetium, it can be detected with a PET scan. So this series of images shows us that it is upper GI bleed, because the bleed is happening in the upper region of the abdominal cavity. Now, like I said, one of the most common causes of upper GI bleed is in esophageal varices, which can be easily detected on a contrast enhanced abdominal CT scan. As you can see, this is the liver, and these is the retroperitoneal esophageal varices. Esophageal varices are actually dilated and tortuous blood vessels around the esophagus. They are usually present in the lower 1/3 of the esophagus, and this causes frequent bleeding, frequent upper GI bleed, and may result in frequent and multiple hematemesis, that is the episodes of blood vomiting. Now, any esophageal varices must be corrected immediately, and one of the most common method to correct is called TIPS, which is the transjugular intrahepatic transportal shunt, where we perform the shunting of the jugular and the hepatic system, and the pressure on the vessels around the esophagus is reduced. Because of the reduced pressures, this dilation and tortuous effect is reduced, and bleeding is then in effect reduced. Now, the next topic of discussion is non-specific issues. Now, what are non-specific issues? Any issue that is unexplained. Number of studies has been done, number of examinations, number of tests has been done, but still the symptomology of the patient is unexplained. So these kind of issues are usually termed as non-specific issues. And one of the most common cause of these non-specific issues is a pancreatic mass. One such image is this one. This is pancreas. This is the pancreatic mass, which is actually a mass in the islets of the pancreas. This is the tail and this is the head of the pancreas. And this mass of the islets is causing unexplained symptoms. Another cause of non-specific issues is hepatic steatosis. Now, in this image, you can see that the density of the liver is less than of the pancreas. This is due to the presence of extensive fatty tissue inside the liver, because hepatic steatosis is also called fatty liver. So because of all this adipose tissue, the density of hepatic tissue of hepatic parenchyma has reduced than the even spleen. This is another image of the fatty liver where it has lost its isoequic properties. Now, another cause of non-specific issues, unexplained symptoms, is ascites and cirrhosis of liver. Now, ascites is defined as the presence of water or serous fluid in the abdominal cavity. And this causes the abdominal cavity to bulge out, usually at the anterior abdominal wall. Now, this axial contrast enhanced CT scan tells us that this is the ascites. This is all the water that is present inside the abdominal cavity, and this is the cirrhotic liver. As you can see that the normal density of the liver has reduced because of the presence of a lot of connective tissue, a lot of cirrhotic changes inside the liver, and its normal parenchyma has lost. Another cause of unexplained symptoms can be a cavernous hemangioma. Now, in order to diagnose a cavernous hemangioma, what we perform is called an axial multi-phase contrast enhanced CT scan. And for that CT scan, we use a portal phase scan. Now, in this portal phase scan, we can actually find out the blood that is present due to the portal vein inside the liver. So this is the cavernous hemangioma that has taken all of the right lobe of the liver, and as the study has phased, as time has passed, the centripetal enhancement has occurred and cavernous hemangioma has reduced in size. So this is very indicative of a cavernous hemangioma inside a liver. This is a 10-minute delay scan. Another cause of unexplained symptoms for a patient might be due to an adrenal mass. Now this is the kidney and this is the adrenal gland, and this adrenal mass is of low density. Whenever adrenal mass is of low density, it is usually indicative of an adrenal adenoma, and adrenal adenomas are usually very benign. Next is the ulcerative colitis. Now, imaging in ulcerative colitis is very important. Why? Because we see a number of changes which only happen in the ulcerative colitis. We see thickening of the mucosal membrane, we see mural edema, we see a lot of other changes both in the abdominal X-ray and in the axial CT scan. This is the thickening of the mucosal membrane and the presence of air inside the colon. Now, if we perform a coronal contrast enhanced CT scan in a patient with ulcerative colitis, we can see all of these features. The mucosa has enhanced, there is mural edema, that is the edema that is present inside the layers of the colon. There's the serous surface, and all of these symptoms produce typical effects of ulcerative colitis. Both the mucosal enhancement, the mural edema, and the hyperenhancing of the fluid. Another cause of unexplained symptoms can be a pancreatic pseudocyst. A pseudocyst usually follows an episode of acute pancreatitis. Now, this is the pancreatic tail, this is the stomach, and this is the pseudocyst. Now, this is not a true cyst because it does not have clear borders. There is only fluid that is present because of the inflammation due to acute pancreatitis. And this pseudocyst can sometimes give non-specific issues, unexplained symptomologies. So, what did we study in today's lecture? We studied about the abdominal imaging, what modalities to use, which modality to use in which situation, MRI is used in what condition, CT scan with contrast enhancement is used in which condition, ultrasound is used in which particular condition, even PET scan. We learned about the PET scan and its use in the staging of various cancers. Then we learned about the abdominal pain. That abdominal pain is sometimes diffused, it is sometimes referred, but still studies and exams and different tests must be done. So we learned about various radiological studies that can be performed when patient is suffering from an abdominal pain. We also studied about the GI bleed. We studied about the upper GI bleed, the lower GI bleed, what is the difference between those, and what is the cause of the upper, what is the cause of the lower. We studied about the intestinal obstruction. We learned about various conditions which may result in the obstruction and the entrapment of the air inside the intestine. We learned about non-specific issues which may cause unexplained symptomology in the patients. We learned about jaundice, what causes jaundice, what causes the increase in the bilirubin in the blood, what causes biliary dilation. All of this we learned in this particular lecture. So thank you so much for watching scardia.com. Thank you.